Welcome to tonight's Words event. I'm Sarah Dawson from Western Alumni, and I'm joined today by three of Western University's leading researchers to discuss the unseen and untold consequences of COVID-19. We are lucky enough that they will be fielding your questions tonight, so please draw your attention to the bottom of your screen where you're going to see the Q&A feature, and we'll get to as many of those as we can today. I'd like to mention the webcast is going to be recorded, and so it will be available to view on demand on the Western Alumni webpage as well as the Words webpage. And now I would like to take a few minutes just to welcome our panelists. Dr. Eric Arts is the Canada Research Chair in HIV, Pathogenesis and Viral Control. He serves as a professor at Western's Schulich School of Medicine and Dentistry. An internationally renowned expert on vaccine delivery methods, disease progression, drug resistance, and the global spread of HIV, Eric and his team are currently working on a COVID-19 vaccine. The professor in Western's Department of Sociology, Kate Choi, is the acting director of the Center for Research on Social Inequality. A family demographer and quantitative sociologist, her research examines the nature of determinants and consequences of social inequality. Prachi Srivastava is a professor in Western's Faculty of Education. A thought leader in the field of global education, Prachi is an expert on global education policy, education equity, private schooling, and global philanthropy. Thank you to all three of you for being here. Eric, let's get started with you. You get the number one question. In recent weeks, we've learned that Pfizer and Moderna are edging ever closer to an effective vaccine for COVID-19. We're wondering, what does this mean for the vaccine that you and your team are working towards at Western? And are you buoyed or deflated by this news?
I'm, excuse me, just clearing the throat. I don't have COVID. I got tested, but no, I'm very, very excited about the news this week. It is a big relief to many of us, and as I was talking to my co-panelists, there's very few vaccines that have ever been developed that have shown this level of efficacy. So I'm really looking forward to getting this rolled out very rapidly and to getting it administered in Canada. And fortunately, we have procured the dosing we need from both Moderna and Pfizer to move forward, regardless of the vaccine that is delivered. And I'm also quite pleased because knowing the nature of how this vaccine works, I think there is a great hope, and the data already shows that not only has high efficacy, but the safety data shows that it's going to be very safe. And of course, we always are concerned about long-term effects of vaccines. But in the course of the study that they've done, there's almost no side effects. And that is very encouraging. And it's very important to stress that this is one of the simplest types of vaccines that could be available of all the ones that we're looking at in the future. And there will be more that will be available to the public. So it's good news, and I think we can all breathe a bit of a sigh of relief, but I always want to stress that now is the time to really put a stop to transmission. So I'm really fearful that our population will just kind of go, oh, well, we don't need to worry because the vaccine's coming.
Yeah, that would be a real concern as we see behavior changing, feeling like we're going to have a vaccine, all of this is going to be eradicated, and we don't have to be as vigilant as we have been in the past. So what I hear is keep being vigilant in terms of your safety and health. On that note, what kind of safety precautions must be taken to ensure proper distribution of COVID-19 vaccine? Can you talk about maybe what kind of obstacles marginalized populations in Canada and around the world face in terms of receiving safe and timely vaccines?
Yeah, so that's one slightly disappointing news, not disappointing news, but one challenge that we face in delivering this vaccine is the cold chain aspect. And even Moderna's vaccine still needs to be stored at cold temperatures, it doesn't need to be stored long term at minus 80 degrees and distributed to sites at minus 80 degrees Celsius, which it poses a big challenge in the distribution of these vaccines across the country. Like in London, Ontario alone, we may need as much as storage for as much as 100,000 doses during the period of time that we'll be needing to vaccinate our population. And that puts a big strain on the economies, local economies, but also in procuring the storage space that we need. These minus 80 degree freezers are hard to come by right now because the demand is so high. So that poses a challenge for us. Now, we are a high income country. We can afford this type of distribution. We know how to provide it. Our healthcare system is pretty robust, even though I would say there are even cracks in our healthcare system. But when we start looking at lower income countries, even middle income countries, this becomes a huge challenge for them. There's very few places. I do a lot of work in sub-Saharan Africa, and there's very few places that would have the storage capabilities that is necessary to distribute this current vaccine. So, and then the other problematic aspect relates to who will have access to this vaccine first. And this vaccine is only effective to stop COVID-19 in the small world we live in, with all the travel and commerce that exists, is we can't think of it as if we just vaccinate the population in Canada, we'll be safe. We need to vaccinate the population around the world. There is no place and no country where this virus doesn't touch. And that is problematic. And if we don't vaccinate everyone in the world, this virus will come back into our populations. And this is kind of what happens with flu. And this is why we have recurrent epidemics of flu every year. And that's because, well, the vaccine isn't perfect and it isn't 100% effective. And as a consequence, it hides out in different populations, and then it comes back and circulates around the world every year. And we have to provide a vaccination to everyone around the world every year. And then the last thing is, and this is a very difficult thing for us to understand, but the anti-vaxxer movement could be our greatest nemesis in controlling this pandemic. And, I can tell you where I side. I'm not an anti-vaxxer, and just the opposite. And I really hope that the people will heed the information that's being provided about safety and understand that these are safe vaccines, and it's important to protect their population. And we need to ensure that more than 60% of the population gets vaccinated in order for this to really be controlled. And I hope that people will view this as like a polio epidemic, and people will be trusting in getting the vaccine because they need to trust us. And nobody wants to take a vaccine that's going to be harmful, but we need to make sure that we vaccinate everyone.
Yeah, thank you for that. I'm thinking about communities and neighborhoods, and I'm thinking about how there's so many people in our world and Canada that are marginalized and maybe not having the same access and the same ability to maintain health and wellness as others. And Kate, I'm going to lob you a question over here and ask you if you can talk about this topic, because you've been studying Canadian neighborhoods and specifically their physical infrastructure during this pandemic. Can you talk to us about why COVID-19 spreads faster in low-income communities, and how has this been exacerbated by longstanding problems in Canada?
That's a great question. So we know in the very beginning of the pandemic, we thought that COVID-19 was a great equalizer, affecting the affluent and the poor alike. That is far from the truth, and we're finding that every day. COVID-19 amplifies existing inequalities. And some of my work with my co-author, Patrick Denise, shows that in Canada, particularly neighborhoods in Toronto, you actually see that COVID-19 spread much faster in low income neighborhoods than it did in middle or higher income neighborhoods, in large part because low income neighborhoods have fewer desirable amenities that promote health and more undesirable amenities that are detrimental to health. For example, a key public health measure for us to stay safe right now is physical distancing. But if we kind of think about how what is needed in order for us to engage in physical distancing is that there be enough space, say, in the sidewalks, and the sidewalks be properly maintained. Lower income neighborhoods are much more likely to have poorly maintained infrastructure, including sidewalks that may preclude individuals from socially distancing from one another. Another particular aspect of poor neighborhoods is that it's much more likely to have overcrowded households where there are a lot of household members for a given space. Therefore, the implications of living in an overcrowded household is twofold. The first one is that an overcrowded household, by definition, will have a lot of different household members that belong to different social milieus and therefore have many more diverse points of exposure to the virus. The second thing is, in the event of an infection, it will all be the case that people cannot self-isolate. So that's one way how residents of lower income neighborhoods are much more susceptible to COVID-19 infections than their counterparts who are living in more affluent neighborhoods. And finally, it has to do with the amount of dependence that perhaps residents of low income neighborhoods have. For example, if it is in fact the case that public transportation is not readily available in middle and high income neighborhoods, people can just drive to different places. But if you are part of the low income neighborhood and you're a resident there, you're less likely to own a car. Therefore, you need to really rely on public transit. And if you are in public transit or you have to do a lot of different transfers, you're much more likely to be exposed to COVID-19 and have the infection. So these are some ways that physical amenities can contribute to inequality across neighborhoods.
Yeah, thank you for that, Kate. In my past conversations with you, it's my understanding that we rely mostly on census and survey based on social, demographic, and economic data. Why is it important that we look beyond age and income as we start collecting information? And how can that contribute to us curbing the spread of COVID?
That's a wonderful question. So one thing that we know about this particular pandemic is in Canada, as well as other countries like the United States, United Kingdom, and places like Brazil, racial minorities are more vulnerable to COVID-19 than in terms of both infection as well as death rates. So if we kind of think about what is the ideal way to curb a particular pandemic is to identify vulnerable populations, understand why they're vulnerable, and actually introduce different policy measures that can kind of address some of their vulnerabilities. And that's the best way to actually curb the spread of COVID-19. And if, in the absence of data such as racial data, it will be the case that it's very hard to actually look at, I know exactly who is particularly vulnerable. And in the case of Canada right now, there's aggregate data on race that researchers such as myself are kind of pulling together to kind of identify these patterns. But ideally, what you would want is high quality individual level data that is collected uniformly across the different nations. Because if we kind of continue to rely on neighborhood data, it is possible that individuals who are living in neighborhoods with high shares of racial minorities, they may not be a racial minority themselves. There may be also a lot of heterogeneity within a particular population as well. So what we need is very good, precise sociodemographic data on COVID-19 patients, as well as those who do not have COVID-19, so that we can actually measure with more certainty the risk of being infected with COVID-19.
Thank you so much. I'm going to jump in with a question from one of our listeners, and I think this is a good opportunity to have a bunch of you jump in, because I see Eric's head nodding and Prachi's too, and I think this really ties in. Is we have one viewer who's concerned about triaging protocol with respect to vaccine distribution, particularly as it relates with pre-existing conditions and people living with disabilities. So as we think about collecting information and understanding who's at risk and then who gets to be prioritized for this vaccine, can you give us your thoughts? Tell us what you're thinking. Whoever wants to take that one.
Well, I'm gonna make a comment, and then I'm gonna shoot a question to Kate in relation to that comment, because I think she can comment on something like, so one of the things that, Kate knows very well that there's no difference in the susceptibility of different races and ethnicities to COVID-19 in SARS-CoV-2. So, there are underlying conditions that are found in all populations, maybe some have higher frequencies than others, that make the disease more severe. But we're all susceptible to COVID-19. And I'll let Kate comment on the fact that, really it's access to medical care that is often the big problem. And so on a vaccine and in regards to who would get it first, and I think it's pretty well understood that we need to protect their healthcare workers first and foremost, because I think you see it in the U.S., like in Wisconsin, and it's coming up in Ohio now, that they're just asking nurses and healthcare workers to come in even if they're infected, because they have such shortages. So we need to get those people vaccinated first, but then it'll really fall to those people that have pre-existing conditions, that potentially have mobility issues, a whole bunch of different factors, and that's where I get concerned that those are the hardest people to reach in terms of needing the vaccine. So I think Prachi and Kate can comment more on that than I can.
So if I may follow up, Eric is absolutely right. The scientific literature, both in social sciences as well as medical sciences, make it very, very clear that differences in COVID-19 infection rates is not really a biological disposition to the virus. It's much more, and because of systematic disadvantages that certain populations, the poor, the racial minorities, and so forth, immigrants, refugees have. And because of that, they have greater exposure to COVID-19. They perhaps cannot engage in the public health mitigation strategies. And as a result, they are much more likely to have COVID-19 infections and death rates. Specifically, if we look at racial minority populations, the reason why they have higher COVID-19 infection and death rates is because of 4 factors. As Eric mentioned, they have limited access to healthcare. They have greater unmet healthcare needs, which leads to, related to the question, higher levels of pre-existing condition, which increases their risk for severe forms of COVID-19. The second reason is because of their labor market disadvantage. So if we look at racial minorities or individuals who are living in poor neighborhoods, it is the case that they're disproportionately concentrated in frontline occupations, and they're disproportionately concentrated in the type of occupations that require that they be present at work, that prevents them from working from home. And as a result, in their workplace, they have greater exposure to COVID-19. The third reason, as we mentioned earlier, has to do with the neighborhood amenities and the fact that they have fewer health promoting amenities. And then the fourth factor that a lot of different scientists have found, particularly in the US and UK, has to do with racial discrimination, which is linked to which is known to have adverse effects on both mental and physical health. And of course, poor health is perhaps a pre-existing condition that increases people's vulnerability to COVID-19.
Wow, so many things.
I'd like to jump in here for just a second, because I think it's important, that question around triage, I think it's really important to put it into context in terms of the fact that this is a global pandemic. And so when we're thinking about who should be getting those vaccines first, of course, there's going to be a health precursor to that. Of course, people who have underlying conditions who are most susceptible should be first in line. But when we start looking at the systematic discrimination issues, of course, that is going to be affected very strongly according to the societies in which we are. I work, my whole life over the last, for 20 plus years has been about global development, global education, and looking at the interconnectedness of our world. And we, of course, sitting here in Ontario and Canada and London, Ontario, wherever it is you're joining us from, have our lenses. And we look at things according to perhaps race, according to perhaps, income, according to, those social groupings that we are best aware of. But when we look globally, we actually need to understand that the systems that are in place that structure the way humans live in those societies discriminate against different people in different ways. So while race is a very important, and I would say it's one of the big considerations of the literature that's coming out of the UK, of the US, of Canada, we also have to understand that medical literature, social science literature, the production of knowledge, the centers of production of knowledge are highly colonial, Western, Northern enterprises. So what's coming out is this very strong idea that race is a determining factor, and it is, and it's not to minimize that. But in countries in which race is not really the characteristic, we need to understand what those factors are. But what they are all driven by is discrimination, whether it's gender discrimination, whether it's income discrimination, whether it's caste discrimination, whether it's religious, minority affiliation discrimination. So the question of who gets vaccinated first, there's going to be a health precondition that should be detailing that. When we get into the social determinants of who gets access to services, that is going to be contoured very specifically in the communities that we're talking about. So I think that's a very deep question, and it actually, touches on the work of Eric, myself, and Kate in a cross-cutting way. Thank you for asking that question.
And if I may add to Prachi's wonderful point, this is also tied into why it's important to collect detailed, high quality, individual level data. So what may apply in Canada or what may apply in North America may be different than what applies in places like India or South Korea and so forth. But if you have good data across the world, right, we can have empirical evidence that showcases who is vulnerable to COVID-19 in that particular society, who gets discriminated in that particular society, have the empirical data, and based on that, address those individuals who are particularly more vulnerable to COVID-19. And potentially that may be a good way to kind of triage as the as indicated in that particular question.
Yeah, thank you for that. Prachi, I'm wondering if we can talk a little bit about some of the long-term implications that we're dealing with now, like as we start to think about it now, and thinking about students in particular, and how they have really had such a disruptive learning experience going back almost 9 months now. When we think about the learning loss that has happened, and more specifically, how children in different parts of the world, and maybe even different parts of our own country, how will they fare? And will some children fare better than others? And can you talk to us a little bit about what that looks like?
I mean, I think, one of the key takeaways of this conversation, whether it's, coming from a virology or vaccine perspective, or coming from racial inequalities, or coming from the education and economic consequences, is that whenever we get a vaccine, and however effective it is, that is despite all the problems and the production issues and the chain of production problems and issues that we're talking about in terms of distribution, is relatively the more simple problem to tackle. And I know that might be shocking to a lot of our audience, because that is not an easy problem to solve. But when we look at the long-term impact of first of all, the social impact of this, and the direct impact of education disruption on life opportunities of this generation, we need to recognize that these are going to be perhaps effects that this next generation might feel throughout its lifetime. And I'm not scaremongering. I'm citing literature on previous pandemics. The 1918 Spanish flu, for example, had life opportunity, education attainment opportunity, negative impacts on those for people up until the 1980s. Right? That it's almost 60 years. There were consequences to that. Now, we are in a situation now where we're able to model a little bit better. And, I think maybe some of the statistics or facts that I'm going to give out right now are going to be quite shocking to people. They were shocking to me when I read those studies. But there's a modeling study that came out that showed that just 4 months of disrupted education, of school closures, could result in a lifetime earning loss of this entire generation of students globally, which could equal $10.6 trillion loss of income. $10.6 trillion, just 4 months of school closure. In Canada, there's a modeling framework that came out by Statistics Canada that said that the class of 2022, high school students, college graduates, and undergraduate students of 2022, they might see a loss of income of $23,000 to $40,000 for the next 5 years. That all depends on what happens in terms of the youth unemployment rate, what happens in terms of the health of our economy, what happens in terms of learning, the quality of learning that gets lost in terms of disruption. Now, we might think that that's a smallish price to pay, but when you put it in terms of GDP, the gross domestic product, which is one of the main indicators we use to measure the health of our economies, we recognize that in a high-income country like Canada and the US, that could have an impact of about 6% of a loss in our GDP. What does that mean in real terms? So I calculated a slightly more optimistic value of 5% loss, and it comes to about $85 billion just this year, right? These are big, big figures. And the impact of that on all of us, on our society, on our economy, is huge. When you think about the investment that's actually required, there's this idea, and I'm really happy Kate brought this out, this idea of the great equalizer as being, in my terms, dangerous discourse. It's dangerous discourse. There's another dangerous discourse. The other dangerous discourse is around scarce resources, that we necessarily have scarce resources for everything. Of course, I live in the real world and I look at economic models, And yes, there are scarce resources, and there are more scarce resources for some countries than there are for others. And we need to be frugal with our resources. But a high income country like Canada, a G7 country like Canada, could afford to invest, for example, the $3 billion that was costed for Ontario to have a safer school plan, a safer school reopening plan, if it means saving some of that $85 billion loss in terms of GDP. We need to think very critically about how we use that frame. And I'm going to end, just this little bit of the conversation by saying we need to understand that the education disruption affected 92% of the world's children and youth population. That is 1/5 of humanity on this planet. That is 20% of the humans occupying. And those people are going to take care of us, right? They're the ones that are going to take care of us. If we don't take care of them now, and we don't secure their life opportunities by investing the resources that we need, either from our own domestic budgets, whether we are responsible for aid to make sure that we give those resources to countries because we are interconnected. Eric made a very good point about the health aspect being interconnected. The economic knowledge aspect is very interconnected as well. We want thriving economies. We want thriving education systems so we can all flourish. So we need to ask our governments, are we standing up for those values? Are we doing that in our context if we have some resources that we can rejig from different budgets? And I think sitting in Canada, we probably could find them.
Thanks, Prachi. I think that when you put it in those terms and you really spell out those figures, it's an eye opener. And you prefaced it with, these are going to be shocking figures I'm going to give you. They were shocking when I saw them. And it is shocking to hear that. I want to take a question from one of our viewers who's asked something that I think we're all wondering about. So hopefully you guys can solve all our problems tonight. But it's about misinformation, that there's so much misinformation, particularly around COVID-19, that we can consume, and it's coming from a lot of different places. How can we address this challenge with misinformation, and especially when it comes to reinforcing the perception of perhaps a vaccine safety or just health and safety protocols that we're being asked to take to keep ourselves safe and to keep others safe from infection?
Yeah, I want to draw some attention to that misinformation aspect just quickly, and I think there's an issue with trust that exists in our society today, and it's a frustration I have. And trust not only with scientists, but trust issues with government. And then one of the things I draw great attention to is trust issues with other countries. So China is a very good example. So there's a lot of fear mongering and concern about, China created this virus, it spread. And first of all, nobody unleashes a virus on their own population for any real reason. And there is nothing that suggests that this virus was created in a laboratory. What this virus was created by is our close contact with wildlife and our inability to protect that wildlife and treat it with the respect it deserves. So that is what caused these epidemics. It caused the first SARS, it caused MERS, it caused SARS-CoV-2, it caused Zika, it caused HIV. So, pretty well, we can blame most of the modern day epidemics in our inability to stay away from wildlife. And that's a sad part. So I always have big difficulties in trying to explain that to people, that man is not smart enough to create these types of viruses that cause these types of epidemics. It's unfortunately an happenstance of nature. And then the next thing that is a big difficulty is trusting science that has come out of China in regards to things like mask wearing. Okay. So we spent a lot of time debating whether masks were effective or not. And I've made so many mistakes in this epidemic. My family can tell me all the mistakes that I've made are, proclamations I've made that turned out to be false. But the one thing that I knew from the start was as soon as everybody started wearing masks in China, I was wearing a mask. And one of the fears and one of the problems we had is, dealing with our masks safe. So we had our government saying, no, you don't need to wear a mask, where us in the laboratories knew that that was an essential factor. And it was really, there was an aspect related to it that there was not enough masks available for our healthcare workers, and that is a big concern. But that stayed a part of the conversation for way too long, and we didn't trust the information coming out of China on a lot of different aspects in relation to this epidemic. So those are the types of things where we really need better information, and somehow we have to restore trust in the community in what we spend our lives working on. And I don't know how that trust has been broken down, but forums like this does help, because we can try to put it in terms and understanding that most people can understand, and most of it isn't that complicated. It's just trying to get the information out.
So if I may add to that, something that it should be noteworthy is the countries who have the highest COVID-19 infection rates, as well as the highest fatality ratios, are the countries that politicize the public health measures. So if we just look at the south of the border from Canada, we know that that is the case. So the trust that people have towards medical scientists, as well as social scientists and public health officials in countries like Canada turned out to be a good thing. So a little bit more of that could be an effective way to curb the COVID-19 virus.
Then, of course, there's a whole issue around critical thought and critical thinking around if someone is presenting something, to be really critical. Not There's a difference between criticizing and there's a difference between being critical. And I think in our everyday parlance, we've kind of lost that specification of what it means to be critical. And what it means to be critical is actually to be open-minded and ask questions. So if someone is telling somebody that they've read something, the first question to ask is, okay, where did you read it? What was the source of that? Somebody says, okay, I read that masks are really not very effective. And the question is, okay, so where did you read it and when did you read that? Because there's also the question of knowledge developing over time. And we've seen that with this pandemic, what was said in March is very different than what was said in April, is very different than what was said in May. And I've been working on the global education emergency and the education emergency here in Ontario. And I can tell you, I have ended days where my head is literally spinning because the information is moving so quickly. So there's also that lag of, understanding that sometimes somebody like Eric or Kate or myself or whomever, people who are really working on this will have that information earlier. And what people are actually hearing is a lag in that information. So there's that question as well. And I think on that front, universities, and I think that, universities are academic institutions, having these kinds of fora and really bringing that out to the public is really important. So this is like a public good, that we produce. And in this country, we have public universities, and that is very important in terms of mobilizing this knowledge.
Yeah, thanks for raising that. I think it was maybe sometime in April, Eric, that we first met and we did a webcast, and one of the big questions was about mask wearing. And at the time, it was something that we weren't really sure about, and there was a lot of mixed media about what we should be doing. And you and your colleague both said, I'm pro-mask, and I think that's when I got my first mask. And here we are all these months later, and we're all, I think, wearing masks for the most part.
it's funny how, I'm sorry to interrupt, Sarah, but it's funny how things have changed so dramatically in such a short period of time. And it's like almost like ancient history, even though it's only been a few months ago. But I remember going into the grocery store wearing a mask when only healthcare workers were wearing masks. And these villainous stares I was receiving in the grocery store for wearing a mask. But, there was also part of me that says, I don't know too much about this virus, but I know I'm working with it in the lab. And I am going to protect the people around me. And I want to make sure that I'm not getting infected as well. And I know that this is going to have an effect. And now turn it around to where we are in modern day and walk into a store without a mask and see the villainous stares that you will receive. So it is amazing how it's just like Prachi said, if you just look at the literature from the scientific information that was provided in, April and March, it was still very murky, right? But you really need to look at what's being provided now, because our knowledge also improves and changes over time. It's not like we're static in what our beliefs are, and we cannot be dogmatic. And so the scientists that are dogmatic are the ones that maybe we shouldn't be listening to all the time. So that is an interesting thing.
Yeah, for sure. I'm wondering if we could take a little bit of a turn and talk about how the world on more of a global scale is managing and handling this pandemic. Eric, you have previous to the travel restriction had traveled quite a bit to Uganda to do your field work there with HIV and AIDS and working on your vaccine there. And one of our viewers has written in about just the stigma that comes with vaccines in some parts of the world. And just wondering how, based on your research and Prachi, what you're learning and some of the things that you're involved in, how is the world handling it outside of Canada and in the US?
Well, I can say it's in Canada and the US, is like Kate described very well, it is a disease that affects all of us, but it is affecting marginalized populations more so than the more affluent populations. However, it's still affecting affluent populations. And so when you talk about the north and south of the world, which you can want to divide this is a disease of the north, and I sometimes call it the disease of white men. Not because marginalized populations aren't disproportionately affected. What I mean is this is not a disease that is impacting the south part of the world, nowhere near what it is impacting the north part of the world. So, in the south part in Africa, sub-Saharan Africa, people are outside a lot more. They spend very little time indoors. They don't have closed windows. They don't have air conditioning. And this is the way people live in Uganda, for example. Doesn't mean that household contact transmission is not possible. It still happens. But the other thing that is differential is the diseases that they face. I mean, the last thing when you have a fever, you go to the doctor for, the last thing the doctor is going to test you for, even in this day and age, is COVID-19. A fever means malaria in most parts of sub-Saharan Africa. In most parts of sub-equator countries are on the equator in any tropical region. Malaria is what causes fever in almost 90% of the infections. And then you might get into dengue and chikungunya and Zika, but way down the list is COVID, even today. And yet these countries are facing huge economic problems because of COVID. And it's not because the burden of the disease is so great in their country. It's because everything has been shut down for them because the high-income countries, first of all, aren't providing the same amount of aid. And second of all, they're seeing resurgence of HIV infections, TB, and malaria because they don't have the drugs and the treatment, and they don't have the resources that they normally do. And that is a huge problem. And what we're seeing now is resurgence of these diseases. And I say that in sub-Saharan Africa, in other parts of the world, but it's happening in Canada as well. There is now people that are afraid to go to clinics to get HIV tested. And what we're seeing is potential outbreaks in Saskatchewan, for example. There was a nice article that just recently appeared about how this is going to be problematic. There's problems with that in London, Ontario. Most people don't understand or don't know that we had an HIV epidemic in London that was greater than pretty well all of North America. We had the highest incident rates in London for at least 2 years because of our IV drug using population and opioid use. And these are the types of things that get ignored when suddenly your neighbor in an affluent neighborhood is potentially contracting a disease that might spread to you. You suddenly turn it inward and you forget everything that goes around you that is much more problematic. I mean, there in just this year, there'll be 2.5 million people that will die of HIV, TB, and malaria. Now that's down dramatically from 10 years ago when 6 million people died of those diseases. And it's because of the WHO campaigns and the treatment campaigns that really were dramatic in reducing those diseases. We're not going to reach 2 million this year, possibly, worldwide from COVID deaths. So even 2 million is too much. But, at its height, HIV was causing 2 to 3 million people deaths per year. And these are diseases that there is no vaccine. And so every year we have another couple million people infected with HIV, with 10 million with tuberculosis, 300 million with malaria. So these are diseases that really affect these populations. COVID is nothing to them. It's a drop in the bucket. It's a flu. It's a cold. And the one last point I would make is, unfortunately, we see a lot of mortality because of COVID-19, and it's dramatic and it's awful. But one of the reasons why we see a lot of mortality is because of our demographics in age. We have a population that is much older than these low to middle income countries around the world. They don't have the same rates of mortality we have with this disease. This disease also affects people with lifestyle diseases, unfortunately, high levels of diabetes, heart disease, etc. If you move to those countries, those diseases aren't as common. So it's quite a different dynamic in low to middle income countries. And that's something that's really hard to grasp.
Yeah, absolutely. And as we start to think about, how we move forward and what kinds of policies, for example, we start to think about, I wonder, what does that look like in terms of COVID-19? Like how do we look at our policies? How do we look at some of the ways that we're interacting and some of the ways that we're addressing, not just like the lifestyle, I would say, issues with healthcare, but just how we are treating healthcare and who has access to things, and what do we do with that, nationally, and what do we do with that on a global scale? Maybe Prachi, you can kind of jump in and talk to us a little bit about what we can do collectively.
So I've been leading a policy brief for rebuilding and resilience, primarily focused on education. This is for the T20, which is the official engagement group for the G20 summit, which is actually happening this weekend in Saudi Arabia. And that's exactly what we are trying to understand, is what are some of the policies that we can put in place, or some of the measures that we can put in place to enable some level of recovery and resilience. One of the issues I think that we've touched on very strongly, which is the point of this, is the point around inequities and systemic inequities within our systems. So that means there are particular groups of people who are denied access to services, whether that's health, whether that's education, whether that's labor, they're denied those opportunities, and that is not a function. That is not a natural order of things. That is a function of the way we have decided we are going to structure our societies. We do that in our domestic borders, and we do that in the way that we support other countries in terms of Canada being an OECD donor, and we have an official development plan. And that means that we are meant to be giving, for example, 0.7% of our gross national income is supposed to be going to aid. Canada has never done that. We're around 0.3, 0.33. There are Nordic donors that continuously give 0.7 and above. What does that mean? Well, that means that in a time where domestic budgets are contracting around the world, these countries that might not be affected so much in terms of the health implications of COVID, as Eric has pointed out, nonetheless are going to be disproportionately affected by the global economic impacts of COVID, and also the impacts within their own borders. So what does that mean for those countries? That means that their budgets are going to shrink. Their domestic budgets are going to shrink substantially. They have entered the pandemic in many instances with insecure education systems, with insecure health systems, with many, many more inequalities than we are used to. And those inequalities and those systemic differences are going to increase. They won't have the money to meet those gaps. And the aid budgets that are supposed to be coming from richer countries are also going to contract. So there's this whole problem of how do we come out of that? I think there are ways of coming out of that. I think one way of coming out of that is to be a lot more cross-sectoral and collaborative. Not to just think of health as health and education as education, but to think of which parts of that puzzle can be filled by other parts. If I take the education sector, for example, we think of education as just teaching and learning kids in school, but actually education has many more functions. It provides childcare, although it's not its primary function. It provides health diagnostics. It provides meals. In many countries, it provides the only meal that children are going to have, midday meals. That's a health and nutrition benefit. So what parts of that pie can other sectors perhaps co-finance? Maybe health, that tends to get twice the amount of money that education does and has over, if I can tell you, between 2002 and 2018, health has consistently gotten almost double what education has gotten in terms of aid. But maybe part of that budget can be used to think of nutritional aspects or health implementation that we can do within schools, right? So how can we start looking at our systems as systems and not as silos? And I think in Canada or in high income countries, we tend to think that, we've got it under control. This virus has shown us that we have not got it under control, that in fact, we are very siloed. Our provinces are very compartmentalized. Health is health. Education is education. We have no federal body that regulates education in this country. And there are reasons for that. But what does that mean? Why do we not have, for example, a federal task force that is truly cross-sectoral, that has levels of governance within every level of government in our country? Why do we not have that? So I think going forward, if anything, anyone who's worked in emergencies, and I started my career in emergencies in the Balkans, anyone who's worked in emergencies will say that the first thing you want to do is to be crisis-sensitive planning. And the way you do that is to really make sure that you have a cross-sectoral response, that you have people from epidemiology, medical sciences, sociology, geography, data science, education, everyone on some kind of a body that's actually looking at the evidence and looking at the implications. Until we do that, we're going to be caught in this the next time there's a pandemic.
Yeah, you shed a lot of really good points on that, Prachi, the interconnectivity of things in particular. Kate, did you want to jump in? I see your head nodding.
Yes. So I as you both of you so eloquently stated, I think what the pandemic illustrates is how interconnected we are and the potential dangers as a humanity or a society as a whole is the most vulnerable populations influence those who are affluent as well. So I think in addition to designing a holistic policy intervention that can actually look at different dimensions, I think more resources have to be invested towards those who are particularly disadvantaged. Because in the absence of the well-being of individuals who are disadvantaged, we have found out throughout this pandemic that society overall is disadvantaged. And that can be within our countries and high income countries, but it can also be looked at with the global lens, as both Prachi and Eric indicated earlier.
Wow.
I mean, I hate to, one last point I'd want to make is because you don't want to always talk about, how we're all talking about the bigger outcomes and the problematic issues, but there is some silver lining to all of this too. And that is it forces countries now to pay attention to low to middle income countries in terms of education, economy, health, because it's all interconnected. Just like Prachi said, and I'm just repeating what you just said. But the point being is we in the North now are going to rely on the South to protect us from COVID, which is an amazing thing. I mean, and we need them to be immunized to protect us from current spreads of this pandemic in the future. And if I were in the South, I would say, hey, how about our HIV epidemic where we still don't have a vaccine? Maybe you could put that level of interest and resources that you put towards COVID to get a vaccine in a year. And maybe you could find, a vaccine that's killed 40 million people so far since the pandemic started, or the hundreds of millions of people that have been diagnosed and died of TB and malaria. I mean, those vaccines are also feasible, but because they don't impact high-income countries, and because there is not as much of a revenue generation behind those vaccines, we just tend not to pay as much attention to them. But maybe we realize that we're living in a smaller world right now, and these things can jump into the population. And we shouldn't be just dealing with vaccines for diseases that are here now, but there are ways of developing vaccines for diseases that haven't even appeared yet. And that sounds really science fiction, but it's possible. And it's just whether we keep the foot on the gas after COVID-19 or we take it off and we say, oh, there won't be another one of these like we did with SARS, like we did with MERS, like we did with Zika, like we did with Ebola. I mean, every time you see a drop off of interest, and the drop off.
They didn't touch us, right? The way that this one does.
Exactly, yeah.
That's it. Ebola, well, it's concentrated over there. Zika, it's constant. Just don't travel to South America. Just don't go there. This is different. This is very different, and exactly what you've said, Eric, in terms of the implications on lower and lower middle income countries. But I do want to point out, for example, Vietnam, low middle income country, did an amazing job of crushing it right in that first stage. Incredible. They were scared because they didn't have the health capacity. They went in there, they knew what to do because they had learned from the past, and they crushed it. And they were able to actually avoid the kind of economic lockdowns that we had. They were able to avoid, they're still going to have a contraction of their economy, but it's not going to be anywhere near, what we're going to be facing, or a country like India that's looking at the worst economic outcome it's had since independence in 1947. I mean, it's basically wiped out 20 years of positive growth in the last quarter, and gone back to a time when it was still under British rule. How does that happen, right? That is not a de facto. This is not what we are seeing, is not a natural evolution of this virus. What we are seeing is a systematic lack of global policy will and implementation, the way that a country like Vietnam did, or the way that a country like South Korea did, or the way that a country like New Zealand did, or the way that a country like Denmark did. We did not do that. And I think there's an evolutionary process to the vaccine, to this virus that you're dealing with, Eric. And then there are the unnatural consequences of this. And they are very strongly grounded in systems like the kind that Kate looks at in terms of the impacts on racialized communities and discriminated communities. And then there's just the long-term effects. And that's going to outlive this.
Thank you, guys. I want to just take a moment to acknowledge that it's 8 p.m. and that was one of the fastest hours that I've experienced in a long time. We have 2 questions on the queue from our viewers, and we have one more question on our list that we'd really like to get to. So I do want to thank you in case anybody has to drop off. And I just want to say we're going to keep going for a few more minutes so we can answer a few more questions. One thing that someone has written in that I think would be an interesting question to think about is there data available on the marginalization and outright racism being experienced by communities during this pandemic? You know, we talked a little bit about gathering information. Kate, maybe you can respond to that.
There have been some studies that have been conducted in the US, UK, and some that are being conducted at the University of British Columbia right now that indicates that racial discrimination, hate speech, as well as assault related to race has increased exponentially for East Asian populations as a result of the perception and the misinformation that potentially COVID-19 may have been generated in a lab in China, or the political discourse that has labeled this particular pandemic as an Asian pandemic. So we're seeing that a lot. I think this is emphasizes the importance of words, particularly among political leaders, and how that can have a lasting impact and can be a barrier and a systematic reason of oppression for a particular group.
And it's really important that we keep asking these questions in public forums and we raise attention to it so that we can make our communities better and stronger and certainly better places to live. Another question, this one could be a really long one. So I want you to take a minute and give a brief answer to it. We could spend an hour on this topic, but with all the talk of return to lockdowns and closures, as researchers, and I suppose more importantly, as informed citizens, what are your thoughts? Is it time to shut down, or do you think we should keep schools and gyms and restaurants open?
So I mean, we've talked about this in our pre-talk, prior to this meeting, and it's an interesting thing. We're all tired of lockdowns. I mean, we're all tired of wearing masks, and it's understandable. I just want to see friends. I want to go out to restaurants and enjoy that. But I know that that's on the horizon. I mean, we really have to trust that these vaccines are working. And I think you can trust that. So then the question becomes, what are you willing to sacrifice at this stage? I mean, we've sacrificed so much in the last year. And can't we just stick with it just a bit longer? And my point is, we're all going to get vaccinated next year. I can almost guarantee that everyone will be vaccinated next year. And as everyone gets vaccinated, the risk will go down more and more. The amount of new infections will start decreasing more and more. You can take that to the bank. And the point being is, how many people's lives are we going to risk, especially over the holidays, if we don't do this one last time? And I think we can. And I really hope the government really makes a strong plea for that and says, okay, we might start immunizing people in January. Can't we just stick inside and watch really stupid Netflix shows? And Prachi and I were talking about it. We're both watching Hallmark movies and whatever we can enjoy right now. But hey,
secret.
I'm sorry, Prachi, I let it out. But when you brought that up, I wasn't going to let it go. And I think like we can do it. And if we do it, how many lives will we save? And think about if we don't do it. Can we take that on our conscience
But I
that
but I
lock
think there is but I think lockdown, so there's two things here, right? There's absolutely, I think there needs to be some restrictions that are going to be put into place. Absolutely. I think the thing is though, which are the services that are core essential services that we, there needs to be a hierarchy of which services we absolutely want to maintain, and for the benefit of them, which are the more non-essential services that we can, think about closing. So there was a study that came out in Nature that said that restaurants, bars, clubs, these are the top three places, looking at all the literature in terms of the super spreader events and the super spreader new infections. Those are the top three places where they're coming from. And actually schools are like way at the bottom. Scotland just came out with a report today or yesterday that seems to indicate that schools are actually not the place of transmission. That's not where transmission is happening. And so maybe we want to make sure that we want to try and keep schools and hospitals open. Like I feel like
Yeah.
there's a hierarchy, and there's an elephant in the room about the fact that we haven't done a great tracing. Like we've not. Toronto Public Health stopped tracing about a month and a half ago, right? Like it's not actually, and Toronto is kind of the center of one of the two centers of the pandemic here in Canada, and it stopped doing tracing. Why is that? Not because it doesn't have the technology, because it doesn't have the resources to hire the people power to do it. So again, it's a question around how do we, sustain restrictions in society, which we absolutely need, in a way that is equitable in terms of not jeopardizing people's health, but also looking at what we're able to sacrifice, exactly what you said, Eric. And I'm able to sacrifice going out to a restaurant, or not going, not boogieing down on my late nights, if it means that, kids can go to school, and if it means that, the hospitals are not going to be overwhelmed. And, I think, and actually that does require a lot more in terms of implementation of QR codes, implementation of real testing and tracing, which we haven't done, and we could. It's
Yeah,
frustrating.
I'm gonna just make one comment on that, and like I think contact tracing we can do. We can get volunteers. I have students that would be willing to volunteer to do contact tracing. We all do, and that's not a limitation. It's more the organization of that to do that efficiently. And the one thing I want to mention is when I say that we got to lock down and really try to do our best. Of course, there are essential things we need to do and keep open. But the other thing too is we also have to tell the government that, I had this conversation with my wife. I would, I have the funding, I suppose, but I'm willing to give $100 right now to keep our restaurants open, and if we all gave that money, we probably would keep our restaurants, our bars, those service industries afloat for the amount of time that needs to be done. And
Germany actually did subsidize its restaurants, right? It's put in programs to do that. We're not doing, again, these are policy failures. These are policy failures in a resource-rich country. And if you're not going to, we are a frugal people. Canadians are frugal, and it's good. It's the reason why we weren't decimated during the 2008 economic crisis the way that the US was, or the UK. We're a frugal people. But there's a point of being frugal. And the point of being frugal is when you need that money, you've got it in the bank. We do have some money. We're not, I'm not saying we're like in unlimited resources, but we do. And we're not expending them in exactly the kinds of ways that you're discussing, that Kate has discussed. We're just not doing it.
Kate, do you have one last thing to comment before we get to our final question?
So I have looked at COVID-19 rates in Toronto, and I've compared them across the different stages of economic shutdown. And what I can actually show is that there was a consistent rise in COVID-19 infection rates after July 31st, when the transition into stage 3 really happened, that continued on to the second wave of the pandemic. That seems to suggest that we need to actually shut down the economy a little bit more during the holidays until we get the vaccine and the risk of COVID-19 drops down a lot in the following year. We're close.
Almost there. Okay, so we don't want to end with a lot of doom and gloom. And Eric, you may have given away your answer, but one of the things that I want to ask the three of you is if you could please share, what are you reading, what are you watching, or what are you listening to right now during this time to lighten the mood and keep you going? Kate, let's start with you.
This is a little bit of a guilty pleasure, and I've been watching the Antique Roadshow. Like, I watch like 2 episodes when 2 things come out every day at the end of the day, and it puts me in such a good mood. And I think it's a little bit of a parable. Like right now, things may seem like you're like in your grandma's basement, like sorting through old things, through the cobwebs. But with the adequate like organization, perhaps you dig out something. You don't know it's quite as good, but you take it to the Antique Roadshow, and then someone looks at it, it's like $700,000. Like, maybe that's what I want for the world. So I've been watching the Antique Roadshow, although I hope none of my students are watching because I think they're going to make fun of me.
It's possible. It's possible. Prachi, let's go to you. What are you watching?
Eric kind of gave away a little bit of what I'm watching. Hallmark movies. I mean, look, they're nice. Everything is orderly. It's all kind of, there's a happy ending in the middle. It's a lot of patriarchy and underlying sexism that I don't actually agree with, and lack of diversity. But it's okay for that little bit. I'm also watching. I did watch the adaptation of A Suitable Boy, and so like I'm not completely flaky, but I wasn't too thrilled with it. So I'm now gonna reread the book for the 5th time because I feel like the book was amazing. And actually, to be fair, if anybody wants to read that book, you really should. It's like watching a film. In fact, the adaptation kind of ruined the book for me, which is why I'm going to go back and read it. And otherwise, it's like 90s R&B, hip hop music.
Perfect.
Yeah.
Keep it light. Mm-hmm. That's great. Eric, we'll end with you.
I'll tell you what I'm not watching. I'm not watching a single movie or series about a pandemic. About world, devastation. I am watching anything that has a happy ending that's light and frivolous. Books that I read, I mean, they've gone from reasonable literature to absolute fluffy, stories. I don't have the capacity anymore to read anything I would say that's intelligent outside of work. And that's the only problem is I'm sure like the 2 of them, I'm just working like I've never done before in my life. Someone asked me, well, one of the things I always say is the worst thing you could possibly do is open up a biosafety containment lab a month before a global pandemic starts. I mean, and the worst thing you could possibly be in a global pandemic that's caused by a virus is a virologist, which I am. So, so I haven't had a lot of time.
Yeah. Kate and Eric and Prachi, thank you so much for joining us tonight. Thanks for all of your contributions and for all of your expertise that you contributed. For those of you who want to read a little bit more about the Forgotten Ones, please do check out the website where you registered. There's a link to a really wonderful article that walks you through the research and the thoughts of Kate, Eric, and Prachi. And I just want to wish everybody well, be safe, and please do enjoy the rest of the Words Festival. Really happy that we could be a part of it. Have a great night.
Thanks for having us.
Thanks, everyone.
Thank you.